by itself does not affect grading because sometimes you see it as some kind of infarction, but palisading necrosis has some relevance to grading. And like you said, they're GFAP positive and they show this dot-like positivity for epithelial membrane antigen. I'll just say something here. Epithelial membrane antigen, we use it for epithelial tumors, we use it for meningiomas, where you get cytoplasmic positivity. But in ependymomas, you see this dot-like positivity. And in my own experience, I find that the immunohistochemical marker that we buy and use for epithelial tumors, the dilution that we use it at does not work for ependymomas. So if you want to demonstrate this, you should do it at a higher concentration. In our lab, we use it at a 1 in 50 dilution. 1 in 10 dilution, whereas normally we use it in 1 in 50 for other tumors. So for these tumors, when we're thinking of this, we tell the lab, use a more concentrated version of the antibody, and then you'll be able to see these dots quite easily. Myxopapillary ependymoma, just to complete the whole thing on ependymomas, they have the not necessarily looking papillary, this myxoid collars around vessels with this bluish background, and that stains positive with Alcian blue. They used to be called grade 1 tumors. Important to know now that they are all they're graded as grade. They start at grade 2. Myxopapillary start at CNS WHO grade 2. And subependymomas, whether they're supratentorial, posterior fossa, or spinal, are grade 1 tumors. So here again showing you this dot-like positivity for EMA. The MIB in a low-grade ependymoma is low and in a high grade is high. So that sometimes helps you to differentiate. Posterior fossa ependymomas, the trimethylation retention is seen in PFBs. And to call it a PFA, more than 80% of the tumor nuclei have to be negative, have to show loss of expression. RELA fusion can be demonstrated by FISH. And this is an example of a C11 ORF95. But like I said, RELA is not the only fusion partner. And the one surrogate marker for the supratentorial Zefta fusion cases is a protein called L1-CAM, and that shows positivity in the cytoplasmic processes in supratentorial tumors that are Zefta fusion positive. The spinal ependymomas, the high-grade ones, not in all the spinal ependymomas, but the ones which look high-grade, one can suspect a MICN amplification, and this can be molecularly looked at or with FISH. And now there is a nuclear marker available by immunohistochemistry, which is a surrogate for MICN amplification. So, Dr. Tejpal, your comments or any comments from the others on this tumor?
Yeah, so I think, what we need to remember is that the PF ependymomas, which are much more common in children. So I think ependymomas, the most common location in children is the posterior fossa, and while in adults is the supratentorial brain. Generally, spinal ependymomas are more indolent than either the PF or the supratentorial ependymomas. And most young children, less than 3 to 5 years of age, have a PFA ependymoma, which is the bad player. And now we have these markers to diagnose them molecularly. The PFB ependymomas are much better in terms of prognosis. And as Madam pointed out, histology probably, the molecular biology trumps histology as far as ependymoma is concerned. And a PFB grade 3 ependymoma probably will do much better than a PFA grade 2 ependymoma. So that's how in ependymoma things have changed. Supratentorial ependymomas, there has been this sort of acknowledgement that this ZFTA altered or the RELA fusion positive are bad. But recent literature suggests that they are not a very homogeneous group, and many groups have demonstrated that despite ZFTA fusion positive, the outcome is not so bad. Of course, YAP1 is better, but again, ZFTA doesn't necessarily mean poor prognosis. till a few years ago, it was considered to be a poor prognosis, but now we know that the ZFTA altered, all of them are not having a bad biology.
Also, in supratentorial ependymomas, those that occur extraaxially in the parenchyma, my experience, those are more often seen in children and have that clear cell phenotype and azefta. The clear cell phenotype, if you see, like almost looks like an oligo, clear cell morphology, one can suspect zefta fusion.
So actually, imaging characteristic, I mean, most of the time, the supratentorial ZFTA altered in children will be a large cystic ependymoma, cortical ependymoma with smaller solid component, and not very close to the ventricle. You're right. They are mostly.
I meant extraventricular. Sorry. Yeah. Sorry. Yeah.
Extraventricular.
Yeah. Yeah. So when they're extraventricular and in children, and with that clear cell morphology, zefta is high on the cards, right?
Yeah, even as I said on imaging, now most of the time we are actually able to tell large cyst is one of the common features of a ZFTA altered extraventricular location in a, say, a 3-year, 4-year, or a 5-year-old child. Most often we will get the ZFTA alteration seen.
All right, and prognostically, the two bad ones are the zefta fusion, or at least the supratentorial with the high grade. Like you said, there is some heterogeneity in their prognosis there, and the spinal MICAN amplified. And
yeah,
then
MICAN amplified is poor, and PF is universally poor.
Bad. Is there anything else there? Any questions? Otherwise, we move on to the next case. Good, Shanti, you did well with that case. So we move on to the last one. This is to Shatabdi.
Good evening, ma'am. Good evening, ma'am.
Yeah, good evening.
Case number 5. The patient shows complaints of imbalance while walking for the last 2 months.
I'm sorry, I think I missed giving you the age. It was a child. I think I mentioned it in one of my earlier versions, but it seems to have got cut. Okay. Kajri?
Yes, ma'am. So this is an axial post-contrast T1 image. And in this one, this also, it looks in the similar location. It's basically a CP angle sister lesion, which is present on the left side. And in this post-contrast image, we can only comment that it's a heterogeneously enhancing lesion. So the peripheral portion of the lesion is showing some enhancement, and the central portion is showing necrosis. Do we have only one image, ma'am, for this?
Yeah, I've only left one.
Okay,
I didn't kind of
Okay.
focus on that. Yeah. So what we had here was that it was a very vascular tumor. Surprisingly, had a well-defined plane, but was also arising from the vermis, but there was a kind of clear plane of demarcation in some areas of the tumor. So let's go on to the slides, Shatabdi.
In this slide, it shows cerebral cortex where we see the convoluted gray zone area, which is supported at the central by branching white matter. And at the periphery of the gray matter, we see multiple diffused small round blue cells.
Are those tumor cells or normal cells?
It seems to be tumor cells.
So I deliberately kept this image, this picture, because I wanted you all to be cautious of this. These are the cerebella folia, and this is actually the leptomeningeal tissue in between, okay? This is the molecular layer of the cerebellum. And then this is the granular layer. And then comes the white matter, which we're not really seeing, except maybe here. So these cells in the granular layer look like dark blue cells. But actually, when you see it on hyper, they'll be very monomorphic, no mitotic activity, and so on. And you have to be aware of this because what happens in tumors that are high grade and blue, which we're going to see shortly, the adjoining nervous tissue can, like this, can look discolored intraoperatively. So when the surgeon goes in, they see these discolored areas and they give you this for frozen. And you do a smear on something like this and you say that it's a high-grade tumor, you will be wrong because it's probably only the granular cells that you're seeing of the cerebellar cortex. And one clue to it is you'll also see some pink zones and these Purkinje neurons that are normally present in between. So I just wanted you to be aware that these granule cells can be very deceptive, but will be mitotically, there'll be no activity. So that was the normal tissue submitted, and this is actually the tumor. Go ahead.
Ma'am, in this section, we see at the low power, we see multiple microvascular pale iron areas.
Micro, nodular or vascular?
Micronodular, ma'am.
Nodular. Pale areas, yeah.
And in the much higher vision, we see again this soft tissue shows multiple micronodular reticulin-free pale islands, which we indicates.
How do you
And
know it's reticulin free? You can't, at this point, you can't say it's reticulin free, right? For reticulin free, you need to do a reticulin stain. This is only an H&E, correct? So you're right. You're seeing some paler nodules and they're surrounded by more
desmoplastic areas, desmoplastic tissues.
Shatabdi, you have to be a bit careful, huh? Desmoplastic, reticulin, all that is seen only with the reticulin stain. What you're seeing here are these hyperchromatic, hypercellular, internodular zones. Do you agree? These are more cellular than the central, these nodular zones. So at this point, you can only say that it has a nodular morphology with these hypercellular zones and the nodular pale zones. Correct? Do you agree?
Yes, ma'am.
Now you have a diagnosis, I know, and you're trying to get to it, but you need to only be able to, you cannot come to that without those special stains. So now you have further high power view of these areas. You want to describe them?
Ma'am, in this picture, we see multiple hyperchromatic round to oval types of cells, mainly the small blue types of tumor cells have been appreciated. Along with, we can see some mitotic activity.
Yeah, that's better seen on this hyper, where this internodular zone is showing you.
Internodular zone.
Yeah, it's
Ma'am,
showing
in this round to kind of polygonal type of tumor cells with small blue tumor cells has been noted with increased
So,
mitotic activity.
there is a high nuclear cytoplasmic ratio, right? So it's hypercellular. There's a high nuclear cytoplasmic ratio, which means the cytoplasm is scanty. The nuclei are oval to elongated, and the cytoplasm is scanty, and you're seeing possibly some mitotic activity. So with just this much, with this nodular appearance and this, which group of tumors are you thinking of, and what would you like to do next?
Here I'm thinking of a kind of embryonal tumor of the
Yeah.
CNS.
Yes, it's in the cerebellum.
Cerebellum.
So which is the embryonal tumor often seen in the cerebellum?
Medulloblastoma.
All right. So you were talking about various terminologies you used while you were describing. Is there a special stain you want to do?
A special stain, reticulin stain can be done.
Okay. So you want to do a reticulin stain, and immunohistochemically, what marker will help you confirm a diagnosis?
Ma'am, synaptophysin.
Yes. So you would do synaptophysin, GFAP, and to make sure it's not a high-grade glial tumor. So this is the reticulin stain. And what are you seeing here now? Now you can say what you were saying earlier.
Yes, ma'am. In this section of the IHC,
Yeah,
of the special stain,
Yes,
sorry,
yes.
ma'am, it's a
Yeah.
special stain. We can see multiple micronodular pattern
Yes.
show with reticulin free area. There is a pale iron.